Good evening, everyone. Thank you for joining us, and thank you for Medtronic for offering this opportunity to see you all. Let me start to talk about from triage to surface reactivation, how to protect yourself. And actually, as Dr. Hani and Dr. Am said, that there is no enough evidence about most of what we said. So this is like more than, it's a personal experience more than a real evidence, but I try to investigate the evidence as much as I can. First, I would like to say that this presentation in the memory of our colleagues and friends, doctors and medical staff who died while fighting COVID. We have one of our colleagues here in acute and orthopedic who died today. May all their souls rest in peace. And I like to acknowledge my professor Ahmed Hunaim and my colleagues Dr. Al Adel and Dr. Amr Ibrahim for preparing a manuscript containing some of this lecture, and my dear colleague Dr. Mohammed Abghani for helping translating some old Arabic instructions. Thanks to my wife to help me photographing what you will see today, and thanks to my little daughters for keeping quiet while I'm presenting this. We are where we are now. Actually, most of us as surgeons, we like to have a strategy or a scenario, and then we have a plan B if things go wrong. But nowadays, I prefer to have a three-scenario approach. The best case scenario, and this is like what said by Dr. Hani and Dr. Amr, that you have to have a full PPEs and you have a very good operating room with negative pressure, other things. And the worst case scenario, when everything is going down, and the most likely case scenario, which is coming up and down towards the best case scenario and worst case scenario according to your situation. So what I will show you today is mostly the worst case scenario, so don't be upset. In this pandemic, which patient need to be operated? Actually, there is no standard definition about the urgent cases that we need to do. And if a patient can wait, how much time he should be waiting. So the decision is for the surgeon to balance between the risk of a significant deterioration, availability of resources, and the possibility of patient to catch a COVID-19 during this area, and the best approach for those patients, which approach can be done. So in the beginning of this pandemic, we start to have a thoracic surgery triage. We try to divide the pandemic into three phases, and each phase according to the availability we work with. So phase one, it was the first case discovered at our center, and hospital resources was not exhausted, and there was no large number of cases. So we just like try to treat patients with malignancies, patient for curative intents, priority to patient who's having asymptomatic lung cancers, and most of the benign lesions was postponed, and even a less aggressive tumor like carcinoids or a tumor less than 1 centimeter that was postponed. So you can see here like a 3 centimeter right lower lobe nodule, and we do it uniportal VATS, and we only add on just face shields to our usual protocol. But with phase two, there are much gush of COVID patients, and start to have limited capacity or access to the intensive care. And at that moment, we try to make a surgical management only offer to those who will not survive for a few days if not operated. And we try to find an alternative surgery. If it's an advanced tumor, we try to have an adjuvant therapy, a new adjuvant therapy before they go to surgery. And as you can see, like here, this man having an endobronchial tumor and obstructive pneumonia, and patient is having a cough, hemoptysis. So we have to operate him at that stage. And finally, the phase three, and this when all the resources are occupied and allocated to the COVID patient and nearly no ICU places. More medical staff is getting infected or working in a quarantine hospital or helping in the front lines. And here we only perform surgery for a patient with hemodynamic instability or airway severe compromise. And as you can see in this photo, this was a malignant pericardial effusion, difficult to be drained by synthesis. So we do an open pericardial window. During this time, we have a large number of trauma patients. A trauma patient cannot wait. And even if you have in your hospital the facility to have a PCR, even this PCR is negative. This is not exclude because patient might catch infection while he's coming and the PCR is not yet positive. So our recommendation that consider every patient to be a positive patient and try to have a full PPE for all surgeons working in a trauma suite. Try to minimize the intra-hospital transfer of patient to multiple areas and avoid diagnostic procedure that would not affect the decision. And if the patient needs a non-urgent intervention, we prefer to have a CT and CPC before he's going to this intervention. And as you can see in this CT, this patient is coming with a motor cap accident, and the CT looks like a score 4 COVID patient. The benign lesions, most of them can wait. Yes, pictus, hyperhidrosis, but the infectious one, which is common here in our locality, as like chronic empyemas, they can be toxic, or you just put a chest tube to drain the toxemia and said leave the patient until we change. But this, as you can see in this X-ray, this patient having a chronic empyema and stand with a chest tube for 70 days, 70. So when we go inside, you can see that the calcium deposition, and we have to operate the patient. So we have to have a balance between waiting and even in benign lesions. So this is our curve in Egypt, and you can see the phase 1 from the start of first discovery of cases nearly to the end of March, and then from April till the mid-May, it was phase 2. And now we are on phase 3, and we only operate on emergency basis. So if this is a situation, and most likely some countries is recovering now from this, and they are trying to reactivate the service. So when can we reactivate the service, and how can we reactivate the service? First, we have to have the components, the elements to reactivate. And here the hospital resources and the type of patient that you will do, and managing your wait list. So every surgeon is looking forward to return to the usual surgical routine. And you have to think about your hospital resources. You have the limited resource at the chain of supplies and number of nurses who's going to the front lines or getting infected. Available ICU beds, personal protective equipment, and limit access to diagnostic work. At that time, most of the diagnostic bronchoscopy is postponed or canceled. Pulmonary function test is the same. So limited access, and the availability of PCR and other tests for every patient and medical staff. So so the thing is, if I have this resources, if I have these hospital resources, do I go now and do my patient as usual? In fact, this is a paper that was mentioned by Dr. Hani about the COVID Surge Collaborative, about the high mortality and morbidity in patient who's having a perioperative infection and undergo surgery. It's more than 50% pulmonary complication and more than 20% mortality. Even some of those was having a PCR preoperative and was negative, and postoperative they discovered to have a COVID positive case, and then they have this rate of complication. This is a large cohort of patients, more than 1,000, and a little bit most of them having an urgent cases. But again, this is a very large number of mortality and morbidity, and should be addressed well with every patient. And the second point is the patient factor. You have to know that you will deal with the post-COVID patient. And as you can see, like we have a lot of scans now, and as in this CT, this is a COVID positive patient, and he's having like a hiatus hernia. So you will have to work on this patient, even if not urgent on urgent basis. But here you have to adjust the timing between infection and operation, and how the lung infiltration will fade out. So you will work, or you will just wait for 2 weeks and then you will operate him. And the accidental findings, or as I said, as I name it, by chance screening. We don't have a screening program for lung cancer here in Egypt, but as a large number of patients now is having scans, so you can have something like this one on one of the screening or diagnostic procedure for COVID, or you can have simultaneous finding, or patient with symptoms that looks like COVID, and when he's having a CT, you find a large lung abscess, and this is common in our locality. So you will have to deal with those kind of patients. Might be at one day they were symptomatic. So now how to reschedule, how to deal with your wait list. First of all, you need to start your outpatient clinic again. We have closed outpatient clinics for the time being. So you have to reopen the outpatient clinic where you can see your patient. You have to have a full diagnostic workup, working pulmonary function test, and bronchoscopy. And then you have to have a look to your last year audit to see how many patients that you usually deal with, how far you did this year, and then how much patient you think that they are waiting for you, so you can allocate your resources and calculate how much staplers and instruments that you will need. And then what I call a balanced admission. You will have a large number of patients who's a little bit critical, and this is a patient demand. And you also will have a hospital workload. You will have, you need to have a patient that going operation and not stay much in the hospital. So you have to have a balance, and then you have your residents teaching, and the residents is doing a very large and marvelous job today in the hospitals, and maybe they are doing some kind of operations or work that is not their primary role. So when it is finished, they deserve to have some teaching. So I recommend to have some balanced admission. This is, I think, is important to have a large. Not all the cases are very bad cases. Some is a little bit for training of those residents. And what to expect when doing this. What to expect when doing this reactivation, according also to the COVID surge trial. There's a large number of operations was postponed, about 28 million around the world in this 12 weeks duration. And they think that if you increase your workload after your reactivation to 20%, then you will finish this number of patients in about 45 weeks. 45 weeks. So it's like it will take you like 1 year to finish the waiting list. So the recommendation is patient consultation about the possibility of complication and morbidity. Stick to what you do best, and this was done. There's no time for trainee or trainings. Limit the number of those during this pandemic. strict to what you use best of PPEs. There is some new Cochrane review about that long gowns were more protective than overall suits because people is not very well trained on the overall suits, but this is a low certainty evidence. And I think this is time for more telemedicine and use of GPs for remote or for routine follow-up. Last part of our for my presentation is how to protect yourself, and this is again it is a personal experience. I hope to share it with you. First, for the surgeons who are not working in Egypt, this is a small idea about that the medical practice in Egypt. We have a public service, private hospitals, and private office or clinic. Most of the time, the surgeon is working in the street. We are allowed to have in the morning, like to go to a university hospital or public service. In the afternoon, maybe we see some patients in the private office. And then at night, we can have some like on call from a private hospital and go there. So it's not usual pathway of going to a shift and then returning back and then it's okay. No. So the prevention for healthcare worker, for the community, we know that we have to stick to the hand hygiene and social distance, universal masking. For healthcare workers, same. And when you are working in the hospital, you use appropriate PPE according to the infection control thing, but there is no prophylaxis so far. I return back in time and look for the history to see if there is something that they use, because I cannot find in the recent literature. And this is from the Introduction to Quarantine Rules by Claude Pay in 1834, and it was at the time of plague. And he said that it's simply 3 rules: wise use or limit excessive food, meat, and alcohol, cleaning in person and surrounding, and lastly, the encouragement and mental well-being. And I think this last one is very important nowadays. We all having a burnout, even we are not operating much, but the atmosphere and the sadness is overwhelmed. So this is a very good point to try to catch. And then we have to think how we can get infected in the hospital. And according to the recent publications that said that in the hospital, most of the places that having contamination is the floor, because it's a droplet infection. So droplets going down on the floor and on the exhaled vent. So if you consider this, you can know that your shoes is something that you have to think as a source of transmission of infection outside to the outside of the hospital, and the air vent that sometimes in a closed atmosphere and not good ventilated places or not a negative suction places, you can catch the infection as an airborne. So we have to be cautious for this. And as a result of this, the general recommendation is a golden rule that consider everyone you treat, work with, or meet is a positive, and act as you are a positive too. On arrival to the hospital, you change all your clothes and keep them in a closed locker or a bag. And then after you finish, you get a shower inside the hospital if possible, and dress by your clean suit, and especially if you are using a public transportation. Use PPE as your local infection protocol instruction, but be prepared for your worst case scenario. And here, worst case scenario, if you will rush to put a chest tube or bronchoscope or something, you have to be having, get prepared for this. Avoid contact surface in hospital as much as possible. I know this is very tough to do this on a 12-hour basis. And lastly, do not socialize inside the hospital. Avoid going to the resident room and staying without masks, without anything, because it is very difficult and you can catch infection. For the private office, I would share some recommendation, because most of us in Egypt are having a small private office and not fully equipped. And as I was saying in the beginning of this meeting, that the temperature today in Asyut was 42. So it's very difficult to have this PPE, and it's not having an air condition. So what I did is that I make the reservation on phone call first, and schedule patient on different intervals, so no traffic. One accompanying person only, and spacing on the waiting area. Chairs are do not face doctor, as you can see here, and about 1.5 meters. I use an overhead mask and face shield and long gowns to the inside, and the lab and scan reports they send me through WhatsApp instead of having them with the patient coming. Fridge ventilation is preferred, of course, but if you don't have, as me, I transfer my desk to be just in front of the air conditioner, so the currents of air is from below me to from me to the patient, not the opposite. I know that there is an EDIS current inside the room, but at least I'm trying to mechanically prevent this as much as I can. I said that this is the worst case scenario, and decrease the patient examination time as possible. Arriving home, again, this is the worst case scenario. I get the shoes outside, and I spray it with alcohol or diluted bleach, and then with alcohol I take put in my hand and the keys, and then with wipes I take the wallet, phone, headset, everything. I put it just very close to the door. And here, this area, as no guests nowadays, so I use the reception area as my dressing room now, or dressing area. I put it here. If I will get all my clothes out and then put it on the washing machine. This is the preferred scenario. If I will use it again, or it's very tough to wash it on a daily basis, so I will put the clothes on the sun. If I'm coming late night and there is no sun, so this is the worst case scenario, I use steam, and it's not evident that it can eradicate virus, but at least I'm trying to push the virus away as much as I can. After I finish all this, I remove the mask and take a shower, or through washing if I take the shower at the hospital. Last thing is that you have to have a long-term plan, because what we are having now is the new normal, and this definition is coming from the new normal is started at 2008-9 during the financial crisis. Some books are talking about that this is chaotic. What means that you have to prepare yourself for a long-term ups and downs during that time. So I try to save my surgical mask and N95 for the hospital. I use a closed mask when I'm going to the supermarket. Sometimes I need to buy the surgical mask or N95 due to the shortage. I change my perfume to one of the local ones who's having a 70% alcohol, so I use it for sterilization as a perfume. So this is an example that you need a long-term plan for your prevention and precautions. Do we have a prophylaxis for COVID-19? In the Egyptian protocol, they started to use a hydroxychloroquine for prevention, but as the New England Journal of Medicine said, it's media and social forces rather than a medical evidence to have something as a prophylaxis. And then people start again to search for something for prevention or prophylaxis. They use lactoferrin, and even the Egyptian protocol use it for treatment of mild cases. And 2 papers only is available for this. One was withdrawn, and the other one is on 75 patients and about 256 contacts. And they said that it's cruel, but it's a very small number of cases, so I'm not recommending this. On the first report from China, they said that talk about the TCM, which is a traditional Chinese medicine, and they said use it for mild cases or use it for treatment, but not for prophylaxis. And then there's a paper coming from China also about using it in prevention, but it's a weak evidence, and a lot of herbs know or little about the mechanism. And also there's Dr. Sameh, an Egyptian doctor working in the States. He was getting infected, and he said or claimed that he used the Chinese herbs at inhaled instead of using it for drinking. Again, there is not much evidence so far. The Nigella sativa, which called the black seed in Egypt, some papers about it. Again, it's very modest, and there is no much evidence about this one. And all things, they use everything, even water, having a publication about fighting COVID with water. And this is a viewpoint, it's even not experimental to be applied. And interesting, they even prophylaxis spray, and this is the Ministry of Defense in UK, said that they inspected the use of Mosigard or some of the insect repel to be used for this, and I could not find any trial protocol or hypothesis about this one. Maybe the only thing that looks like a scientific way is that the use of betadine mouthwash, and this was one study, in vitro study, about its efficacy, and it works well. And now there are a phase 2 trial registered on clinical trials about using of a povidone iodine intranasal and for gurgling for the healthcare workers, and it should be continued for 3 months and then see the result of this one. Maybe this is the only one I might recommend, but all of them is not yet evidence-based. So I take a work message, as we all in home now. I think that stick to proper infection control measures, wise use of food, and proper mental well-being. Be ready for the worst case scenario and hope for the best. Social distance, especially inside hospital, and be aware of this pseudoscience that is very popular nowadays on social medias and even for scientific platforms for doctors, because it's not, it gives you a false sensation that you are protected and you are not. So the real protection was proper infection control. And what I add on now is not yet proven, but at least we try to add this to, but not to replace what is formal infection control measures should be done. And lastly, I want to finish with the advice from Claude Bay on the old days physicians should strive to do whenever they are in human clemency should require them to do examine the patient by inspection and palpation and perform the necessary operation. Thank you all.